So we're now live on YouTube.
Yeah, we've got three attendees.
Oh yeah.
It should be live on YouTube.
Yep.
So we're now live on YouTube.
Yeah, we've got three. Bit of feedback. Hello, everyone who's just joining. We'll just give a short pause while we let everyone get in before we get started. I'll give it a couple of minutes. Give it one more minute and then we'll just get started because of timing, guys, if that's okay. All right, we'll just get started. So good evening, everyone who's signed in already. Thank you for joining us for our first BOTA bare bones session. So these sessions are for medical students up to CT2s and hopefully give you some good sort of basic topics on our core topic for our Sunday supper each month. So this month we're talking about hands, and we've got two of the BOTA committee to deliver some teaching for you. So Romina, who's going to talk for 10 to 15 minutes on hand anatomy, and Alison, who's going to talk about flexor sheath infections. We've also got myself, who's the Vice President, and Shiv, who are helping to run the sessions. If you've got any questions, please ask them in the Q&A and we'll field them at the end of each session, and hopefully you find it useful. So without further ado, over to Romina.
Thank you, George. I'm just going to share my screen now. Okay. All good? Yep.
Yeah.
Perfect. Okay, so good evening, everyone. My name's Romina. I'm the current BOTA SAC rep and also the TIG Hand Fellow. Today, I'll be giving a short talk on anatomy of the hand. It's a fairly big topic, but we'll do a brief overview and hopefully you'll find it useful. So just to begin with, the things that we'll going over, that would be useful to just understand the orientation and terminology that we use in hands is slightly different to other parts of the body. And then we'll go over bones, which hopefully will be very familiar to most of you. And finally, look at the soft tissue of the hand and particularly the digits involving the musculature and also the blood and nerve supply. There are other parts like ligaments, etc., that I won't go into detail just because of the scope of this talk. So orientation and terminology. That's slightly different to other parts of the body. When we're talking about anterior aspect of the hand, we don't normally say anterior. We regard it as palmar or volar. And similarly, the term posterior hand isn't really used. It's the dorsal. The same is for proximal and distal end of the hand. And the other thing to remember is when talking about or describing injuries or anatomy of the digit, the borders itself, you can say medial or lateral, but we tend to say radial and ulnar, particularly because of pronation, supination of the hand can become confusing. And again, particularly as depicted in the thumb diagram, the volar aspect and dorsal aspect are the terms used to describe the anterior and posterior of the thumb. Okay, so moving on, the bony anatomy, hopefully we all know this, but the 27 bones of the hand consist of phalanges, which are subdivided into distal, middle, proximal. Be mindful that the thumb has two proximal and distal, metacarpals and the carpal bones, which comprises of 8 bones and 2 rows. And now, when these bones articulate, they form joints And the way to remember if it all gets confusing is think about the two bones that are articulating with each other. So with the phalangeals, it'll be interphalangeal joints, and you have the distal, DIPJ, and the proximal, PIPJ phalangeal joints. And then with the MCPJ, it'll be the metacarpal bone articulating with the proximal phalanx from the MCPJ. Note that with the thumb, there is no DIPJ, PIPJ is simply interphalangeal joint. Similarly, moving on more proximal, you have the CMCJ, so the carpal bone articulating with the metacarpal, forming the carpo-metacarpal joint. And whenever the wrist, particularly the distal radius, articulates with the scaphoid or the lunate, it's known as a radiocarpal joint. Okay, so taking a closer look at the carpal bones, just to orientate ourselves, this is a 3D image of a left hand fold aspect, and this is the thumb base. So going from the proximal row, we have the scaphoid, lunate, triquetrum, and the pisiform. And then going back to the base of the thumb, you've got the trapezium, the trapezoid, capitate, and the hamate. They're important to remember, and there's various mnemonics out there to help aid the what the bones are. And so the one that I've used in the past is this. So it's a more sort of PG rated one. Sally left the party to take Kathy home. So use whichever works for you, really. Okay, moving on to the muscles of the hand. Very big topic. The way to sort of broadly divide them, there's intrinsic and extrinsic. So what are the differences? The key difference is intrinsic muscles of the hand, they arise, originate, and insert within the hand itself. And extrinsic muscles, they arise from proximal, whether it's the forearm or the distal humerus, and their tendons insert in the hand. That can be further subdivided into volar and dorsal. We'll be paying particular attention to the volar tendons of the hand, and the dorsal is not so much covered in this topic. The intrinsics, again, can be subdivided into the deep muscles, the interossei, lumbricals, the thenar, hypothenar, and adductor pollicis, which doesn't really fall into any of the above groups. So firstly, going to the sort of the most deep layer of the hand, you have the interossei muscles. So commonly, the palmar interossei are 3 muscles, and the dorsal interossei are 4 muscles. And they have the role of adduction and abduction of the digits. And the way to remember is the pad and dab. So palmar interossei allows adduction of the fingers, and dorsal allows abduction of the digits. So lumbricals is another, there are 4 lumbricals, there's another important intrinsic muscle group. They arise from the radial side of the FDP, the flexor digitorum profundus. And you can see structurally you have the 4th and the 3rd, the lumbricals actually are bipennate, which means the fascicles of the muscle arise from both sides of the tendon. And the 1st and the 2nd are unipennate. Essentially, they insert into the extensor mechanism. Important to note as well on the picture is the flexor retinaculum, because that forms the roof of the carpal tunnel, where the deep flexors, the FDP, flexor digitorum profundus, and FDS, along with the FPL, go under the tunnel before they insert to their respective positions. So what are the function of the lumbricals? The main function is MCPJ flexion and IPJ, so both PIPJ and DIPJ extension, as shown by the diagram on the right. Okay, a quick note about thenar and hypothenar muscles. There are 3 muscles that comprise the thenar, and that's the prominent muscle bulk on the palm aspect of the radial side of the palm, and they control the motion of the thumb. You also have the hypothenar, which is on the other ulnar side, that control the motion of the little finger. And that in itself has a deep and a superficial layer. Adductor pollicis doesn't belong to any of the groups, but it's an important muscle to note. It is a triangular shaped muscle, which has a broad sort of size of origin, including the metacarpals and the capitate, and it inserts into the base of the thumb. It's important clinically because if this is on the right diagram, shows the UCL rupture of in the base of the thumb, which is the ulnar collateral ligament. If that ruptures, it is the adductor pollicis aponeurosis that causes a block to the UCL being repaired, and clinically this is relevant because it will likely need surgical repair. Okay, so moving on to the anatomy of the finger. This diagram used to always throw me off, quite a lot of things going on, but it's important to break it down into sort of the extensor side and the volar aspect too. So firstly, looking at the extensor mechanism, if you follow me through with the metacarpal bone, and you can see the dotted lines outline the bony landmark, so that's the proximal, middle, and distal phalanx. You have a central extensor tendon that then forms part of an extensor hood. Now this extensor hood, also known as extensor expansion, receives the lumbrical and the interossei tendon, and together they form this expansion, and it has the first insertion point, which is known as a central slip at the base of the middle phalanx, and that allows PIPJ extension. From the extensor hood, you have two lateral bands that arise, and they meet again at the dorsal aspect of the distal phalanx, causing DIPJ extension. And this is just a radial view of the structures mentioned. So as you can see, there's a long extensor tendon, the extensor hood, coming through with the interosseous and the lumbrical muscle, forming the central slip here, the lateral bands going along the middle phalanx, and then finally becoming the terminal tendon and the DIPJ. So then, looking at the flexor tendon anatomy, so the dark color, the dark green, depicts FDP, which is flexor digitorum profundus. It travels along with the FDS, which is the flexor digitorum superficialis. And you can see on the diagram on the right that once the FDS and the FDP pass the MCPJ, which is here, the FDS then splits. And this is the two arms are known as FDS slips and form this chiasma, also known as chiasma of Camper, allows the FTP to then travel through the two slips and then finally insert into the distal phalanx. And the function of the FTP here is DIPJ flexion, and the FDS continues to insert into the middle phalanx, and that causes FDS flexion. PIPJ flexion. So an important thing to note with the flexor tendon anatomy is where does it get its blood supply or nutrients? And it's from these structures called vinculum, and they're found on various points along the tendon. Again, very crucial for tendon with regards to tendon injury or tendon healing. Okay, moving on to the blood supply. Key things to take home here are that the main blood supply comes from the radial ulnar artery. They together form deep and superficial palmar arch, and then they in turn arise and form common digital arteries. Each common digital artery then divides into two arms, and the two branches go into the borders of the hand, or the fingers. So as mentioned in our first slide, so if the artery falls into this little finger here, this would be the radial digital artery. And then the artery that goes along the ulnar side will be known as the ulnar digital artery. And similarly with the nerves, it will be UDN or RDN. Okay, the main thing is with regards to the venous drainage, there's an extensive dorsal venous network, and they all form to drain into the cephalic vein and the basilic vein. And moving on to the nerve supply, the main three nerves, as we all know, are the median ulnar and the radial nerve. Easiest way to remember is the radial nerve are principally responsible for finger extensors through posterior interosseous nerve, which lies in the floor of the fourth compartment, the wrist compartment, and also supplies the motor function of Adductor Pollicis longus. Moving on to the ulnar nerve, main thing is it supplies most of the intrinsic muscles of the hand. And the way to remember it is with the mnemonic HYLA, so hypothenar muscles, interossei, lumbricals, but remind yourself that it's actually the medial 2 lumbricals and adductor pollicis. This is key in clinically when you're examining for ulnar nerve dysfunction, adductor pollicis with the Froman's test. As you know, if you allow them to hold a piece of paper and you get FPL for action and they're unable to adduct the thumb, it does indicate ulnar nerve dysfunction. Another thing to note is that the ulnar nerve supplies the FDP to ring and little finger. And then moving on to the median nerve, it supplies all the flexor digitorum superficialis tendons and muscle, FDP to index and middle finger, as well as the FPL to the thumb. And so commonly we ask patients to make the OK sign, again, flexion of the IPJ of the index and FPL IPJ flexion of the thumb to assess that function. And another mnemonic to remember median nerve supply to the hand is by the mnemonic LOAF. So standing for lateral 2 lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. As finally, the bottom picture shows the cutaneous supply of the hand. So firstly, on the dorsal aspect, you can see a majority of the cutaneous supply is via the superficial branch of the radial nerve, and the little finger, and half of the ring finger is supplied by the ulnar nerve. And then on the volar aspect, the median nerve is the predominant cutaneous nerve supply. Again, ulnar nerve supplying the ulnar side of the little finger, and a very small patch supplying the superficial branch. For accurate testing clinically, I use for the radial nerve, I use the dorsal web space of the thumb, and for the median nerve, the index volar side, and for the ulnar, the little finger volar aspect too. So in summary, hopefully we've gone through the orientation and the terminology for the hands, gone through the bony structures that hopefully most of you are aware of, and we've sort of whizzed through the muscles and tendons and the blood and nerve supply too. Hopefully you all found that useful. Many thanks.
Great, thank you, Romina, for that. Let me just check this. So I don't see any questions in the Q&A. There's one person with their hand up. If you want to ask a question, if you just type it in the Q&A box down at the bottom, that's the easiest way to do it. I can see Catherine and Sarah. So if you just type it to the Q&A box, and that's the easiest way for us to try this. Okay, no questions, great. So we'll move on now to Alison, who's going to quickly talk to you about flexor sheath infection.
Hello, right. George, can you just confirm, can you see my presentation and can you hear me all right?
Yep, all working great.
Fantastic. Right, start the timer. Good evening, everybody, and Noswithar from snowy South Wales. My name's Alison. I'm an orthopaedic reg here, and we're going to get a bit clinical now. We're going to talk you through flexor sheath infections and why you'll see all your seniors get quite so agitated about them when you have one. So basically, if you see a patient with a sore, swollen red finger and you take this to one of your seniors, I guarantee you that they will ask you, is it a flexor sheath infection or a flexor tendon sheath infection? So that brings up the question, what is one of these? Okay. So the clue is in the title. It's an infection within the sheaths that surround the tendons of the muscles on the front of the hand that do this. And it's, for reasons we're going to go into, it's a surgical emergency, which is why it's so important to be able to spot it early. Usually, but not always, this arises as a result of a penetrating injury. And there are a couple of usual suspects that have a tendency to do this. So one is ill-advised DIY. Another is cats, which are both a disaster as a film and also as a for the flexor tendon sheath. And the third is the extreme sport of gardening. So this picture here is of blackthorn. This is a really common hedgerow plant in the UK, and as well as producing beautiful sloes to make lovely gin, it has these really vicious thorns on it, which can go right through your gardening glove and into your joint or into the sheath surrounding your tendon. The problem then is that you've let bugs from the outside into these tunnels, these synovial sheaths that surround the tendons, which is basically the ideal habitat for bacteria. And it's all happening under the surface. So you may have just a little puncture wound on the skin that you can see, but yet the infection is rocketing away underneath the surface and through into the hand. So what are these hidden spaces I'm talking about? Well, as I said, in order for the flexor tendons to glide nice and smoothly and to allow you to have really good function of the hand, surrounding them, you've got these synovial tunnels, and these link up throughout the hand. Now, this is ideal to get your flexor tendons to work, but the problem is you've basically created all these little conduits for infection to spread through the hand. And this arrangement you can see here is the most common arrangement for these tunnels. But as you can see in the next picture here, there is quite a lot of variation across the population in terms of how these tunnels are laid out and how the network links up. So you can easily see, looking at some of these road maps, that you could have an injury, a small injury to the near the tip of one finger, and have that spread either all the way into the palm, into the carpal tunnel, or even up into other fingers. So how do we know if we've got one of these infections? Well, there are 4 cardinal signs that have been described by this guy called Canavel, which are what you need to look for to see if this is what you've got. And this is what they are. So basically what you're looking for is a big red swollen finger. Sometimes the word fusiform is used for this. Sausage digit is maybe more descriptive, but basically a big red swollen finger. It's usually held in slight flexion, so slightly curled in, and it's painful if you try and stretch it out. And this is because, as you can imagine, if that tunnel is all full of pus and is tight and inflamed, to then try and sort of move and slide that tendon inside it is really, really painful. What is also painful is if you press on the tendon sheath. And this can be a really helpful sign to look for, because if you have an injury up here, but when you're pressing down here, it's still sore, there's a good chance then that the infection has traveled underneath the surface through these tunnels. So I think this is the key slide to remember. This is what I want you to really focus on, is the fact that you're looking for a big red swollen finger held in flexion, painful when you straighten it out, and painful when you feel down the flexor sheath. And those are Canavel's signs. So why do we make such a big deal of it? Well, as I said, the first thing is how this infection can spread through the hand into other areas. But the second thing is stiffness. A huge amount about hand surgery is about function, because that's what your hands are for. They're there for dexterity. And if you have a nasty infection surrounding your flexor tendon, it can either completely eat through the tendon and rupture it, or it just produces a lot of adhesions, which means that, and scars up that tunnel, which means that that tendon will no longer slide and you'll end up with a stiff finger. And it is surprisingly debilitating to try and live your life with one stiff finger that you can't manipulate. In addition, there's the issue of soft tissue loss. The hand is full of essential clockwork, which is all in very small spaces and very close to the surface, because you haven't got much spare space in your hands. So you can imagine in your finger, it doesn't take a particularly big abscess or a particularly big area of necrotic skin from a nasty infection before you have either a massive stiff scar that's deforming your finger, or a hole that goes straight through to the tendon or the joint. And in some severe cases, you can even lose the finger due to the infection. And this is what you can see here. So this is a case I've pulled off the internet, but you can see this is the start of the patient's operative journey. You can see a big red finger here. And rather worryingly, you can already see some redness and some sort of ulceration going on all the way down here. And in this case study, this is the after picture of how this patient ended up. So you can see they're missing part of their finger and the bit that's left is not looking terribly healthy. And you can see from all the redness around here and where the scar is that this infection has tracked all the way into the palm, possibly down into the carpal tunnel, and maybe starting to creep up into some of the other fingers. You can see this is a devastating result for this patient from what was possibly quite a minor injury that started it all off. So now I've frightened you to death by showing you that horrible hand picture. What do I want you to do about it? Well, like I say, the most important first step is just to suspect it. So like I say, anytime you see a cat bite or a sore swollen finger, ask yourself, could this be a flexor sheath infection? And if you think it is, then you need to tee this patient up as an emergency for a surgical washout. This is one of those cases where the bugs and the infection are all within this enclosed space. So it's going to be very difficult to treat it without physically washing it out of that space. And I won't go into too much detail as to how we do this because it's much easier to learn in practice. But basically, there are two options. What's done most commonly is you'll start off with a patient like this, and you can see where there was the penetrating injury here, and you can see all the redness and swelling and the flexed finger here. And then what they've done is they've marked out the proximal and distal ends of where that tunnel is. And they've labeled them A1 and A5 because this is talking about an extra bit of anatomy, which is the pulley system, which you can always have a Google of, and that will explain why we use those landmarks. But basically, they're marking out an area at each end of the tunnel that they then open up with a little incision, open up the tunnel, and then slip a cannula in it to be able to wash out that tunnel with a bit of saline. There are all sorts of tips and tricks as how to do this. It's quite a cool operation to do. So if you want to know more about it, either asking the questions or even better, approach your local orthopaedic registrars or hand surgeons and then they can talk you through it. If this isn't possible, if you're not going to be able to manage it through this minimal approach, or if things have sort of advanced a little bit, then you could be left with having to open up the whole finger, which you'd do using a zigzag incision like this, a Brunner's incision. What else are we going to do about it? Well, no surprise, we want to hit this really hard with some IV antibiotics, and I'd advise you to talk to your local microbiology team about what to give, particularly if there's something might be unusual in there, like something from an animal bite. Elevation is important for all hand swelling, and something that's shown here, which is called a Bradford sling, is a really good way of providing really good elevation. And also you want to rest those tendons and rest the hand. And we usually would do that in a resting splint or a resting plaster, which we'd put in what we call the Edinburgh position, which is roughly like that. Again, we can talk about that a little bit later if it's new to you, but it's basically the safest position to rest your hand, and it allows the swelling to go down. And again, I'd encourage you all to speak to your local orthopaedic registrars about Bradford slings and resting splints, because they're the real sort of bread and butter treatment for a lot of hand injuries. And that's me done. Thank you very much, everybody.
Great, thank you, Alison. So, any questions for Alison or for Romina?
So we had one question in the chat box, in the Q&A box, from an anonymous attendee. They said, you had mentioned that adductor pollicis aponeurosis can cause a block in thumb movement following UCL rupture. How common, roughly, does this occur following UCL rupture?
I think Romina's typed to say that she's answering it. Romina, do you mind just talking through that one?
I can answer if Romina's not on the line. I think what she was talking about is not so much that it causes a block to the thumb movement. The problem is it causes a block to the ligament getting back where it's supposed to get. So the problem with these injuries is your thumb gets deformed like this, often from catching it on a ski pole or something. Everything gets stretched, the ligament pings off, and then it flicks out from underneath the aponeurosis. So then when your thumb flicks back again, the ligament is then blocked from its normal site, so it can't heal on. Again, easier to see in a diagram, but I think that's what she was meaning about the aponeurosis causing a block. It's not so much a block to the thumb movement, because the thumb will move fine. It's the fact that the ligament can't heal, which can leave you with a bit of an unstable thumb.
Thanks, Alison.
Thanks, Alison. Pretty much that. So essentially, sternal lesion can be seen on X-ray if you've got a big flake of bone that's fallen off maybe 5 millimeters away from where it's meant to be. That's a good sign that there's a sternal lesion, and that there'll be a block to the UCL trying to get back to its insertion point. So those cases need surgical fixation or surgical repair. And other times it's not so clear cut. So you might want to use ultrasound scan to assess sternal lesion, or clinically if there's no endpoint and the you've got the thumb and you're moving it to stress the UCL and it just keeps going under local anesthetic, obviously, because it will be quite sore. That's also an indication that there's likely a sternal lesion there too. Thanks.
And then I think there's a question for me, which is from one of my deanery's trainees, I think. So hi Kumar. I hope my answer will be up to scratch. Yeah, the washout. By all means, approach the hand team in Cardiff and check what they want to do, because we all have to do it exactly the way they like to do it. I tend to find that I make, rather than what was shown in the picture, which is a little transverse incision, I tend to make the start of a Brunner's incision, so do it as a slight zigzag, for two reasons. One, because I think it can give me a little bit of better view, but also because if I plan those out and then the patient goes on to need further surgery later, it's easier then to extend that into a full opening of the finger. And I think once you've got a good view and you've got a good view of that A1 pulley and can divide that, you can make a bigger window to get the cannula in. It can be a bit tricky to get the cannula in. But I think, yeah, getting a good view by making maybe a slightly bigger incision is helpful. The other thing I would say about tips and tricks is in our unit, we are discouraged from using large amounts of saline doing this, which seems counterintuitive, because normally when you're trying to wash out an infection, the answer is, oh, more wash, more wash, more wash. But there have been problems of either the cannula not being quite situated right, or it's slipping out or leaking, and people injecting large volumes of saline into a closed space of the finger, which you can imagine is not good. So the key we've been told is, yeah, make sure it's in, check, put a tiny bit in and check the fluid is coming out the other end. And then I think Mr. Trigger says they want a maximum of about 30 mils. So you want to go sort of slow and careful with it and check the fluids going where you're expecting it to go.
Good. Thanks, Alison. There were a couple of questions in the chat as well. So one was about antibiotic starting infectious teeth infection. So would you start it pre-op? I mean, certainly in my unit, I guess it would depend on time to surgery. And ideally, you shouldn't be starting antibiotics until you've got samples. But if you've got a clinically obvious one and they're not going to go to surgery immediately, then I think, yes, you'd start them. I don't know what you think about that, Alison.
Yeah, similar. Yeah, I mean, obviously, it's always helpful to get a culture result before you start antibiotics. But I think unless I was taking them straight to theatre, I would just start them on IV antibiotics. Like I said, most of the infections that cause this are fairly standard bugs, and can be predicted from what the injury was from. So yeah, normally I would just start the antibiotics. If there's going to be any delay to surgery, just start them. Obviously, if they're pyrexia, you can take a blood culture, see if you pick up anything off that, but otherwise start them. And then if you do get a bit of pus in the operation, you can take that. The other option, of course, is sometimes if it's a penetrating injury, particularly if it's something like a cat bite or something, you may be able to, when you first see them, get a little bit of pus out the puncture site. So you might be able to get a sample that way. But yeah, if any doubt, just start the antibiotics.
And there was one final question, was how long would you rest the hand for following surgery?
I think it would depend on what you found in surgery and what your following plan is going to be. In general, you want to start tendons moving, uninjured tendons, as soon as possible, because you don't want them to scar up in place. But obviously with some of these, your first washout may just be the first stage of their operative management. So it's a slight swerve away from that question, because I don't think there is a single answer, but I would suggest just put them in a splint directly after their surgery, and then consult with your hand team about where you're going to go following this. Do you have any set rules in your unit, Romina?
Yeah, so it's really guided by, as you mentioned, the need for further washout, and that's clinical assessment. You know, usually sometimes they need a second washout 48 hours, but within a week you want them in hand therapy. And the key thing is if they've got if they've got a large wound, or you had to do a brunners along the finger, what we do in our unit is we put lots of sutures in, so we can allow mobilization without causing wound dehiscence. So the key is get it mobilizing as soon as, but the priority would be to sort out the infection first. So yeah, within a week, I'd say at the most, and get it going.
Great. Thanks, Ruben. So we'll wrap up there because time's getting on a little bit. So thank you everyone for coming. Those of you who signed up for the Sunday supper as well, we'll see you shortly. If you could, you'll get a link and an email with some feedback. If you could fill it out, that would be great. And finally, just a quick announcement to say that the new BOTA website will be launching this week. And there'll be some more details on social media, so keep an eye on that. Thanks everyone.
And join us next month for wrists.
And yes, next month is wrists, and again there'll be an email with the details on how to sign up for that.